Very much. And when you're, if you are asking a question, we ask that you stand up and you'll be given a mic to talk into so our friends that join online are able to hear the questions. So thanks for that. Our first speaker today is Vibeke Elise Ansteinsson, and she'll talk about co-creating a novel practice model for connecting oral health and home health care services, the importance of users' experiences. I welcome her to the stage.
So is there a clicker?
Is this here and to go back? This one? Yes.
Okay. So thank you, and it's a very nice room to presenting, I must say. My name is Vibeke. I'm from the Oral Health Center of Expertise, located in Oslo, as well as the University of Oslo. I'm presenting today co-creating a novel practice model for connecting oral health and home health care service and the importance of user experience. I will mainly focus on the co-creation process and the user involvement. So the results I'm presenting today is part of a bigger project named CORAL, connecting oral health and home health care service for patients receiving home health care in Norway. And we are focusing on the older adults living at home receiving home health care in the age of 65 plus. This project is funded by the Norwegian Research Council, and it's started in 2021 and are ending in 2025. So I will start my talk with just giving you a brief introduction to the Norwegian healthcare system, as well as the whole CORAL project, before I go into the details of the co-creation process. So in Norway, we have a healthcare service, which is 3-leveled. And there are very few meeting points between the level, especially between the county level, where the public dental service is located, and the primary care level, where the home health care service is located. And also, the majority of the research has been on coordination between the hospitals and the primary care, and not between the dental care service and the home health care service. Older adults receiving home health care often need help with oral hygiene due to functional and cognitive impairment. And older adults receiving home health care in Norway have rights to free dental care from the public dental service. However, very few of the older adults use these rights. And we actually don't know why that is. It's around 20% of the older adults living at home. And a recent article reveals that older adults receiving home health care were more likely to have poor oral health compared with those living in nursing home. So therefore, these services are 2 worlds apart. We therefore have an overall aim of CORAL to co-create together with user groups a generic model for coordinating the home health care service and the public dental service. So the whole CORAL project has 3 main work packages. The first work package is mostly knowledge building at different levels. The work package 2 is the co-creation and implementation part. And the work package 3 is the evaluation part. So we are now just starting work package 3. But today I'm going to talk about the co-creation process in work package 2. Throughout this project, we use the MRC framework for developing and evaluating complex interventions, as well as the rainbow model for integrated care. So, using co-creation as a method in the development of healthcare intervention has been increasingly popular in research. Co-creation can be understood as a joint knowledge generation by academics who work together with other stakeholders outside of academia, often referred to as user groups. And this knowledge generation process is often produced through rich dialogue across professional and service boundaries. In addition, user involvement is also recognized as an important strategy for expanding understanding and to identify the needs of the end users and other user groups in healthcare service. And is also known to give a better research outcome. However, these processes, as you probably know, is not a walk in the park. It's a very complex process, and I like Sander's presentation of this process, a fussy front end. And in my opinion, there is need for more research on the co-creation process itself. In this project, we want to examine the co-creation process, developing this complex intervention for connecting the two services. And in particular, we did the co-creation, how did the co-creation process in Coral facilitate user involvement, and which topic are emphasized by each user groups in the development of the Coral intervention. I must say we are just in the beginning of analyzing this data, so I will just give you a little peek into the data. So our user groups in this project is the older adults living at home. We had 4 of those, and we had 1 next of kin. We had representatives from the home healthcare services, and we had representatives from the public dental service. We had a hard time recruiting participants due to the corona situation. So we would like to have more, but this was what we got. And we also have researchers involved in the whole process. So this is the design of the co-creation process. We had 3 workshops with users, and there were also workshops with the researchers in between. It was kind of separated into 3 phases. The identification phase, where we try to understand the problem and understand the complexity of the problem. We then narrowed it down to the identification of the focus area. And then we did a decision phase on agreeing on the best intervention area. So at the time, we are in the piloting and implementing phase. Throughout this process, we used Cecilia as a boundary object. I will come back to that on the next slide. And for the first workshop, we also used the method patient journey. And for the decision phase, we use the 6 thinking hats. So who is Cecilia and what is a boundary object? Oh, sorry. And then you can look at the screen there. Yeah, but I can. We have used the theory and the term boundary object to describe Cecilia's function in our project. So a boundary object could both be personas or a scenario, or it could also be a patient journal. But the whole idea is to create a common ground for discussion and to mitigate languages and knowledge boundaries between groups. We used Cecilia in this project with creating different scenarios and films. And I will just now show you a very brief film. It's just a few seconds that show you the idea of Cecilia. And she is also created to several iterations and based on interviews with all the adults living at home.
Dette er Cecilia Hansen. Hun er 85 år og bor alene i egen bolig. Cecilia hun ønsker å klare mest mulig selv, men hun er ikke i stand til å ordne alle daglige gjøremål på egen hånd grunnet Parkinsons sykdom og benskjørhet. Derfor får Cecilia daglig besøk av hjemmesykepleien.
So we did audio recording of all the workshop. It was approximately 10 hours. And there was also done observation notes during all the workshops. And the analysis is an inductive thematic approach, although we haven't finished all the analysis yet. So to say something about the results. So how did Cecilia function as a boundary object in this co-creation process? Cecilia facilitated the discussion around all the adults with oral health issues in the home health care service. She guided the discussion and making the users recognize their own situation and relate their experience to Cecilia's experience. And this was the case for all user groups. Further, she facilitated a better understanding of each other's point of view in the mixed group. And she also facilitated a non-hierarchical collaboration. However, it was difficult to get the end users on board in the discussion. So much of the discussion was around the service group, user groups. But I think in total, it facilitated collective learning and networking. All user groups emphasized the same topic, but they shared different experience, views, and perception when they talked about these topics. But one of the most discussed topics was the information system, or lack of. Lack of information between the services and the patient. Several of the patients included in these workshops didn't get information about their rights in the public dental service. And there was also a lack of each other's services. This was the service perspective. And it was also a lack of routines and compartmentalized knowledge about the user's rights in the different services. And it was a blurred understanding of who was responsible for what. And this was also represented by all user groups. So the co-creation process contributed to developing this intervention by unfolding the complexity of this problem from different perspectives. It very much emphasized the lack of each other's knowledge about the services, and it has influenced the design of the intervention, which are in process. But I must say that the older adults included in this study is part of a vulnerable group, and it was during the corona period. And it was also necessary to conduct several interviews one-to-one with all the user groups. And here is a picture of the team. It's a lot of us working on this. So thank you.
Thank you very much for that great presentation. We have time for questions. I'm not sure if any questions have been coming in through the app. We can check that. But if anyone has a question, please raise your hand, and we have a mic that we can bring over to you. Over there.
Very simple question. What is the service looking like now? What did they design?
We haven't gotten to that yet, I must say. We are developing the intervention. So it's regarding information flow in the different services. So it's designed as information flow, and it's supported by technical intervention. The problem is that there are no information between these two services today. And the public dental service do not know who's in the home care service before they consent to give the information to the public dental service. So this is the bridging that we are planning on.
So I think we have time for one additional question, unless anything's come up on the app. Thanks, Marianne.
You mentioned in your presentation that there needs to be more there needs to be more research of the co-design process. I'm just wondering, from your perspective, what needs to happen? What more research needs to happen?
That's a big question, I think.
Just simple, like
I don't know.
Quick, top of mind.
When we started this, I missed maybe some direct, how to do this. methods and like point on stuff. And then also I miss a little bit about how the different groups interact and what works to get the different group to interact in this process. Yeah.
Thank you very much for your presentation. So now we're moving on to our second presentation today. I'm just going to adjust this. So we have Russell Roberts, and he'll talk about experiences of integrated care, consumer perspectives.
Thank you and welcome everyone. I don't know if you're interested in lived experience or this awesome room, but either way, it's a privilege. I'm going to talk about lived experience. I'm going to quickly give a little bit of context coming from a mental health perspective, but I really think the lessons that we learned from this research applies to integrated care across all contexts, and then talk about some of the results, and then talk about some of the implications of those results. So off we go. Firstly, some of the context. Are we equally well countries? No, we're not. So Russell Roberts from Equally Well. People with mental illness die earlier, 13 to 23 years earlier than the general population, mostly of preventable physical illnesses. And it's 2 to 2.5, 2.7 times the population average. This is absolutely not right. This data and the research is compelling. Over 15,000 peer-reviewed articles. Last time I checked, 132 meta-analysis or pooled analysis showing about that life expectancy differential. More likely to die of cardiovascular disease, more likely to die of cancer, much more likely to smoke. And in Australia, at least, 13% of the population who identify or have had contact with mental health services comprise 55% of all cancer deaths, even though the incidence is the same or lower than the general population. Something's going wrong there. And in Australia, for every one person who dies of suicide, 10 die of the top 10 causes of chronic disease. So we worry about suicide and mental health and premature death. We should be worrying about mostly preventable chronic conditions. So what we wanted to do was sort of start to understand some of this. The other aspects of this, if we're talking about integrated care, one of the best, I think, interventions for mental health is good physical health. Poor health, the psychological distress, that's McNamara et al.'s research of a population study in New South Wales, Australia, 4 times the rate. So, and there's lots of evidence of like step 0 treatment for depression is activity, not medication. And that's recommended by the society. Also, when we think about the causes of suicide, I want to just dispel some myths based on the research. It's not schizophrenia. It's not relationship problems, it's not separation and divorce. These are all important. You can see this from the Australian Bureau of Statistics. It's not anxiety, it's not previous self-harm, it's not substance use and drug and alcohol use, it's not depression. No surprise, this is no grand reveal, is it? It's poor physical health. Is the biggest association with suicide. So once again, people do a suicide risk assessment and do these other things. Focus on their health, for goodness sake. One, because it's the right thing to do. We're talking about integrated care and holistic care. But 2, if you want to improve mental health and reduce suicide risk, focus on well-being, overall well-being. Okay, are we an equally well country? This is Australian data. And if you're rolling, if you're going to the casino here and you're rolling the dice, if someone's got a mental illness, there's an 80% chance through the Australian Bureau of Stats that they'll have a coexisting chronic physical health condition. They're pretty good odds. So anyone who's seeing someone from a mental health condition should think about comorbidities. 55% chance that they have 2 or more. And most of these conditions, we're not too sure how many, but between 38 and 69% are preventable. And I'll talk about some of that. How do we approach this? A little bit of context at Equally Well. That's the name. It's about people with a mental illness have a right to be equally well. And I need you to keep me time because I forgot to press my timer, but I'll press it now so I'll get a sense of how we're going. And so we have a collective impact approach to dealing with this issue, and I spoke about this in the Queen Elizabeth Hall, which is such a privilege. And really what we're looking to do is to enhance this through collective impact through all the sectors, the professional colleges, the state providers, the private providers, consumer advocacy groups. So it's meant to be an equal. Every partner provides expertise in this. We are fortunate now that we have a national consensus statement. This is in the National Mental Health Plan. We've now managed to get it into the Cancer Australia Plan. We've got it in for quit smoking guidelines, and we're now advocating to get it in cardiovascular guidelines as well, to make this part, integrated care, part of everyone's work, not just mental health. And in the collective impact, we have a collaborative now of over 100 organisations, which is every Australian government, every peak, every professional college, and a number, not all, but a number of chronic care societies and preventive care societies. We also managed to get this within the state guidelines. Perfect. I know exactly where I am. Perfect. That's great. So we've managed to get this within the authorising environment in terms of the major providers to get that in their guidelines. And this is tremendously important in terms of influencing the authorising environment. When you're trying to influence change and system reform, it's so important to have the data, but also have the policy and have the guidelines and the agreements behind it. But we also work locally. So important to equip people locally, with local GP, local consumers, and those cards are where people choose their goals. We had someone who's had 30 years of mental health treatment and no one ever asked them, what are some of your goals? Shame on us, shame on mental health practitioners. So that person on the side has this thing and say, what are the things you're concerned about? And another one is, what are the things that you'd like to do? So we talked about this morning, about personal goal-orientated care. And so we've got a number of organisations that are progressing this. Anyway, that's my introduction. That's my 5 minutes. Bang on time. You'll be relieved. So am I. Now I want to talk about one little piece of research that we did in partnership with Lived Experience Australia around people with mental illness, their experience of contact with physical health services, any physical health service. And this is where, whilst it with people who identify with a mental illness, I think it applies to anyone with a particular chronic condition. And now this is available on equalel.org.au. You can download this report. We've got 2 publications in submission around this particular piece of work. National survey of about 550 people. One of the limitations, I don't think it's representative. These are probably the people with mental illness who are doing better, the people who are connected and filling in these online surveys through Lived Experience Australia. It's a combination of quantitative and qualitative data. So let's see what they found out. Some of the key findings, which is shocking, and I cannot see this, but I think it's only 1 in 5 found that the mental health professional asked them about other domains of their wellbeing. Shame on us. Holistic care, mental health professionals in Australia just focus on that. And the carers only involved about 25% of the time. This is what we call in this area diagnostic overshadowing. Someone comes with a diagnosis that overshadows everything else in that person's life. And particularly with mental health, because of the stigma and the risk of suicide, they focus on the mental health only. But you saw the data before. One of the biggest predictors of poor mental health is poor well-being and lack of community participation and poor physical health. That's a diagnostic overshadowing, which means that the 13%. In Australia, for example, every single day 16 people die of cancer with a mental illness. If we were the population average, it would be 2 people a day, even though the incidence of cancer is the same or lower. That's the sort of thing we've got to deal with. Only half of clinicians ask about medication, only side effects, only half ask about other things. I'm struggling here because I can't see this, so I'm going to have to do what the previous speaker did and turn around. In terms of carers as well, most people identified that carers were probably the most important person in their care journey, yet clinicians never recognise this. They don't engage. Often they exclude the carers. They don't want them to intervene because the clinician, I'm the expert. I don't need some carer who's got no professional training to help out. Shame on us again. There's an expertise here. Here's an expertise of 10, 20, 30, 40 years of understanding how that person responds to medications and to interventions, and how best to get them to engage and participate in community. And so we've got a long way to go in that respect as well. Carers find that they're often excluded from this, and this is, I think we need to be much more proactive in engaging carers. In Australia, we have a Mental Health Act where people can choose to identify or not, but at the moment, even if they do say, this is my carer, professionals tend to exclude them. I talked about mental health. I can criticise those with freedom because I trained as a psychologist, so you can criticise yourself all you want. Let's talk about GPs and allied health professionals. Much, much better. 85% of GPs did ask about physical health. Thank goodness, because that's their job, is comprehensive holistic care, and they claim that. But, only less than half asked about cancer screening. I just talked about the cancer figures. Less than a third, only a third, asked about if they wanted to quit smoking. There's so many stereotypes here, even though they knew they were smoking. This is people they knew who were smokers, not the entire population, people who are identified as smokers. Great, spot on time. So only a third, and we know that smoking kills half the people who are long-term smokers, and that's probably a lower end of the estimate. Shame on us on not asking, would you like to quit smoking? Now, they can say no, but they don't, and there's so many stereotypes which I won't go into, but not asking about cancer screening, diabetes screening, cardiovascular screening, smoking screening. And these are GPs, mind you, general practitioners. No wonder we're getting that. The other problem, which you probably know, and I think is certainly a case in Australia, affordability is a major problem. We're sort of gradually privatising health services, and even though we used in probably the 80s, we had a universal health system. Gradually, bulk billing for seeing medico is getting less common, and so care is getting less affordable. And guess who can't afford it? The most vulnerable in our population, those who with the lowest income, those at highest risk are those who are least likely to afford it. Some of the findings about the physical side effects of medications, once again, half of people have physical side effects. Very few clinicians ask about it. What is also shameful, if they talk about the side effects, they're dismissed. They feel as though a clinician is not listening to them. So if someone raises a concern about their physical health, half of people say the clinician don't take me seriously. Shame on us that we don't respect the lived experience of people who contact health professionals. The other thing with vaccination preventable, I know I've only got 1 or 2 minutes and I'm just about there. In Australia, and even if you think about the economics of this, vaccine preventable hospitalisations, there's some really recent research that we've done in Australia here of total populations of 8 million, 5 times more likely to die of vaccine preventable conditions, 7 times more likely to be hospitalised. A whole suite of vaccines in Australia is about $50. Hospitalisation in Australia is $2,000 a night. Not only does it improve people's health, it actually reduces pressure on hospitals, and etc. Key findings. Ask about health screening for cancer, heart disease and lung. This is really what we work on. Include families in care planning. Make sure they've got access to resources and information to equip and empower consumers to get the care they deserve. Training people, clinicians in anti-stigma, discrimination and holistic care. Training with consumers and carers. Why should we be concerned about it? It's our job. Integrated care, holistic care is everyone's job. Equity of access is a human right. Physical health increases psychological distress and suicide, and it reduces pressures on hospital. Here's some of the references backing up that. And listen, who is equally well? We all are. So listen, if you're interested in this, we have a newsletter. We also have an international collaborative learning network of people who are worried about this nationally. Go online, equallywill.org.au. And also, we have a free conference at the end of July, which is hybridised. So last time we had about 20% international. Hope to see some of you at our free government-funded Equal Will conference this year. Thank you.
Okay, we're going to keep things moving along, so if you do have a question, do document that and we can get to it at the end of the session. I now welcome Tsoleen Ayanian to the stage, and she's going to talk about how patients define success for integrated care, how the University Health Network identifies iterative improvement priorities. Tsoleen?
Not that tall. Hi, everyone. Nice to be here today. My name is Tsoleen Ayanian. I'm a project manager, surgical lead for the integrated care program at UHN. And I'm going to talk. Ooh. My slides aren't. I can see it over there, but not. Oh, there we go. Perfect. So I'm going to talk about how patients define success for integrated care, how the University Health Network identifies iterative improvement priorities. I don't know why this isn't. There we go. Okay, I think I got the hang of it. So just to level set before we get started, I know there's a lot of definitions and ways that integrated care is applied across different organizations. At UHN, the definition that we use is care that is coordinated, continuous, tailored, and based on shared responsibilities. Before I get into the topic, I just want to give a context around University Health Network. So we are located downtown Toronto, Ontario, Canada. We have a diverse population, quite large, 2.6 million in Toronto, 6 million in the GTA. And we provide quite a range of services across the care continuum, from acute care, outpatient care, emergency department care, primary and rehab, to note a few. Just from the acute and ED perspective, we see around 39,000 acute cases and 121,000 ED visits. And we get patients from all across, not just Toronto or GTA, but across the province, Canada, and even internationally. So in terms of how we've applied the integrated care model to UHN, really it was a co-design with patient partners, as well as alignment with Health Quality Ontario standards. So they had done a patient study around the key things that were important to patients as they transition through care. And so based on that, we came up with these 4 pillars of how we would implement for our program. So care coordination, communication and continuity of care, easy and timely access, and customizable care. And so what that means in terms of care coordination, we have an integrated care lead who oversees the entire patient journey from the start. So for the surgical or medicine population, when there's that decision to operate or when they're admitted, up until they're back home 90 days post-discharge and receiving home care. And that integrated care lead sits at the hospital, close connection with the hospital and our home care partners. We also ensure that a patient has one story to tell through our shared digital record. And so really that shared digital record allows the care providers to see what happened in the hospital, as well as to get timely updates on the care that's being provided in the home so that they can adjust in real time for their next visits. We also have a 24/7 line that patients and caregivers can use. We found that this has been really helpful in reducing anxiety in the lead up to the surgery, or gives them reassurance when they're being discharged, and really enabled by that shared record. So when a patient calls into the line, someone who answers on the other line can look at their record, see what treatments they've had, what care they've received, and direct care on the spot. And this is all really enabled through one fund. So with the program, we now have oversight into the hospital and the home care funding, and we can make decisions differently. So if we're able to discharge a patient home earlier and provide more home care support at those initial days of discharge, we're able to do that because we have that oversight in funds. Even in the home care side, we're able to adjust the home care visits that a patient might receive. If someone is doing better, we can maybe reduce the home care that they're getting and adjust it to those patients who are not recovering as well. So what we've done back in 2019, we implemented this model to start with in thoracic. And we also did an early evaluation with UFT's Population Health Analytics Lab. There's pros and cons to early evaluation, but we found it quite important to do it early, just to get idea of, are we hitting our targets, the objectives we set out to do? Is there things that we need to refine? And so you'll see a summary of those results. We got really great patient, caregiver, and care provider feedback. The model seemed to be working well, supporting patients well. And we also were surprised to see that there was improvements to some of the quality outcomes, even though it was just 6 months post-go live. And so based on that evaluation, we went back, refined, and expanded our model. So the 2020 hit and we had COVID happen, and so we had to pivot a bit, but all to say is we expanded to COVID care, CHF cardiology, vascular surgery, cardiovascular surgery, the ED pathway, we have a GIM pathway, as well as moved on to orthopedics, liver transplant, and this coming year we're going to be expanding across even more of UHN. And so the entire time that we have been implementing, we have been receiving quite a lot of really positive feedback from patients, either through calling the IC leads, sending letters, just saying what a positive impact this has been for them and their families. These are just a few quotes that I'm presenting. Maybe it's easier here. So you can breathe knowing that someone is coming into the house. If it wasn't for the program, I don't know what we would have done. We would have ended up back in the ER. For this for a person living with chronic disease for nearly 40 years and a difficult medical history, your help kept me going, employed, and doing what I love. This person, we had to help them go through a difficult time and ensure that they were able to enjoy Christmas and New Year's and without feeling too deprived. Just a few other examples as well in terms of the really positive feedback we continue to receive from patients. And so it's great to see, to have that feedback, but we don't really have an understanding of maybe where what contributed to that positive impact, nor do we really have a way to measure on an ongoing, regular basis for quality improvement purposes. And so we collaborated again with UFT's Population Health Analytics Lab to come up with what a minimum data set might be to ongoingly evaluate IC models of care. And so there's obviously a lot of existing indicators out there, but we found that none of them really showed that entire journey and really looked to evaluate IC specifically. And so we went on to do a modified Delphi process to identify a minimum data set for evaluating integrated models of care. Essentially, that's just a group of people coming together, coming to a consensus as to what this minimum data set should be. And so the process was a high level of 4 steps. The first part was looking through over 100 indicators, which we collated, reviewed, and shortlisted to 45. Those 45 were put into survey number 1, where we asked participants to rank them to see if they were relevant, necessary, and actionable, as well as provide any written feedback on the question or the wording of the question. Based on those rankings, we then shortlisted it down to 17 indicators, and again asked participants to go in and rank those indicators to make sure that those were the ones we wanted to put in the final set. And that was the last part, just finalizing those minimum data sets for evaluating IC experience. In terms of participants, when we had first started this, we were wanting to at the very least, have 2 to 3 patient and caregiver participants, but we're surprised to find to be able to onboard almost 50% of our participants being patients and caregivers. So we invited 31 participants, and 29 participated in either survey 1 or 2. We found that they were predominantly female between the age of 31 and 60, 13.8% identified as a person with disability, 27.6% as a person of color, and overall less than 10 years of experience across the participants. And so we were really excited that we had such a great representation from the patient and caregiver side. So what that meant in terms of our results, for the most part, both groups were in agreement around the indicators that should move on to the next round. So this is from survey 1, the results. But we did find around 24.4% of indicators were actually rated higher by patients and caregivers versus the admins and clinicians, and 4.4% were the inverse. So obviously with the patient focus and in all things that we do, we wanted to do a deeper dive on that 24.4% of indicators to see, what was it that patients were really wanting to make sure were in surveys or were being looked at. And the question that we decided to collate and move forward was the one on the screen. How did you get the emotional support you needed to help you with any anxieties, fears, or worries you had while being cared for? So really just a great example of the importance of having patients, caregivers provide that voice of what matters most to them. In terms of what this meant for our final indicators, we have two sets of indicators. So the first one evaluates the overall experience of how patients wanted to be treated. And it ties well as well to the UHN patient values that you'll see at the bottom of the screen, but really around patients being involved in their care, the communication between their care providers and caregivers, as well as making sure that we're treating all of them, not just their disease or their recovery from surgery. We also, the next set of indicators were more so to understand the coordination and transition points in care. So you'll see, around the primary care, making sure that we are speaking to the patient, providing them appropriate information, appropriate supports, as we transition through care and they're recovering back at home as well. In terms of next steps, so we did work with UHN's patient experience team to implement the survey for all patients enrolled to the program. We haven't gotten results yet, but hopefully next time we present, we can provide some of those findings. And we've also had some regional interest in leveraging the minimum data set to evaluate IC models of care, which is really exciting. So more information hopefully coming soon. Throughout this entire process, I think we had 3 key learnings and insights that I wanted to share today. While all the work that we do is always patient-focused, we try to put the patient first and keep that perspective in line. It does not replace having that lived experience, having that patient caregiver in the room to provide that perspective. And so that's always important, and we try to ensure that we have them represented at all levels, including during the development of this minimum data set. The other insight was that there needs to be a balance between what we're asking from patients and not overburdening them, but ensuring that we're able to collect enough to be able to evaluate how we're doing as a program. And the final one was there's ongoing patient engagement and involvement doesn't have to be too complicated. So as I mentioned, for the most part, the clinicians, admins, patients, and caregivers had an agreement on what was best to evaluate this model of care. And so it doesn't need to be too detailed or laborious. And we could also use the results of these surveys to help us identify in further evaluations when we do more detailed ones on where we need to focus. If an indicator is not performing as well or is doing really great, we can look into more detailed evaluations at that point. Before ending for today, I just want to give a special shout out and thank you to the U of T Population Health Analytics team. They, as I mentioned, co-led this work and unfortunately weren't here to present their great work, but really grateful to have been able to collaborate with them. Thank you.
Thank you so much, Tsoleen. What a fantastic program of work and great co-design. We do have time for one question, and we have the microphone roaming around, so please raise your hand if you'd like to ask a question. Oh, right there.
Yeah, this is great. Interested in something you said near the end about just the burden of how many questions. So my question might be more detailed. You can give a quick response around how do you know that answer? What's a burden to some might not be to another? And specifically, I'm interested in maybe if you were to add on questions about EDI or demographics because you want to know who answered. So then you're just adding. So just general comments on that.
That's a great question, and it came up during our implementation. So as you can imagine, our survey is probably not going to be the only one that a patient receives once they leave UHN. And so we have to work with a patient experience team on evaluating which questions go to when, some business rules. In terms of what's too much or too little, I don't know that there's a clear answer, but we did try to make sure that we were aligning with the Health Quality Ontario standards of what is important for patients when they're transitioning. So we made sure that we, at the very least, were able to link it back to those, to what our final MDS was. I will say during the development of the MDS, the one that we realized was missing was the question around the primary care, and so we afterwards added that back in because it wasn't included.
So we do have one additional question that came through the app, which is amazing because most people don't use the app, so this is good. And I can't ask for additional context. I'll just read what's read. You said you have had experienced people help you develop the surveys. How did you work together?
Yeah, so it was the U of T Population Health Analytics team that we helped to come together, and so they did a lot of research and literature review on the indicators that were currently present, again, tied it back to the transitions in care that we wanted to evaluate, and they were the ones who helped us finalize that initial 45 length survey, and then eventually to the final MDS of 14 questions.
Great. So join me in thanking Selena for her great presentation. And our next speaker is Justine Giosa, and she's going to talk about designing meaningful surveys, engaging experts by lived experience in the development of a patient-reported experience measure of integrated home and community care.
Okay. Thanks, Carrie, for reading out my very long title. So hi, everyone. Thanks for joining this session today, and I'm pleased to be joining you from Ontario, Canada. My name is Justine Giosa. I'm the Scientific Director of the SE Research Centre of SE Health, and we are a national social enterprise, and within our social enterprise mandate have a dedicated research centre with an applied research lens. So I do have some handouts about our research centre and what we're doing, and some of the other presentations we have throughout the conference. So if you're interested, you can feel free to follow up with me if you want to learn more about us. But really pleased to talk to you about our work to design a patient-reported experience measure with experts by experience. So why do we need a new patient-reported experience measure, or PREM, for home and community care? So as we just heard, it's really aligned with the work that was just presented by Tsoleen, but as we heard, emerging models of home and community care aim to better integrate medical and personal care with community-based social care and services. And so we know as these new models emerge to better meet the needs and preferences of people in the community, we need rigorous evaluation of these models, and it really needs to align to all elements of the quintuple aim, not just looking at reducing costs and other types of outcomes, but really thinking about the experiential lens and understanding how these things are impacting people's day-to-day lives. So some of the issues with existing PREMs in the literature that we found when we went to look for some measurement tools is that a lot of the tools are developed in a facility-based or office-based healthcare setting. And so home care is a really unique context, and delivering services in someone's home is really different than delivering them in an office or in a facility-based setting. And so that context really matters. A lot of PREMs that are existing in the literature capture patient satisfaction with services through a very health systems lens. And so, for example, they're asking some ask about satisfaction with discharge or intake, processes that are really systems lens and not necessarily thinking about the overall person experience of that care. Some PREMs fail to capture equity or inequity in care experiences, and as we're looking at EDI and thinking about more inclusive care, that's something that we should be directly measuring from an experience perspective. And some are narrowly focused on experience of physical care. And as we've been hearing a lot about goal-oriented and life care here at this conference and over the past number of years, we need to be focusing more holistically. And so this type of information, having the right PREM, really can ensure that leaders are making the right decisions in terms of improvements to these types of programs. So we set out to engage experts by experience in a participatory process to develop relevant items for a new PREM of integrated home and community care. So our overall study applies the Striner and colleagues process for health survey design. I'm really going to be focusing in on the second part, or the second phase of our study, where we engaged deeply with experts by experience. But to do that, I'm going to talk a little bit about our first phase, where we explored the literature and looked at over 550 PREM items in the literature and did interviews with some healthcare leader experts to develop just a preliminary item pool matrix. What are some of the things we might want to think about in terms of home and community care and client experience? And then in our second phase, we aim to engage older adults, caregivers, and providers in focus groups and interviews to think about the appropriateness and relevance and coverage of these items and domains from a content and face validity perspective. And then we went on to do some more testing, and I'll talk about that a little bit at the end. So after we did that literature review and looked and had those expert interviews, we had this preliminary item pool matrix, as I mentioned. So this matrix had 3 domains covering equity, continuity, and life care, 14 different categories, which you can see here. So from an equity perspective, looking at respect, inclusivity, trust, and access. From a continuity perspective, looking at collaboration, coordination, and consistency. And then from a life care perspective, you'll see sort of a very holistic perspective on those categories, moving beyond just physical health. And so we ended up with 72 item concepts here, which we know is too long of a survey. So to the question earlier, this is going to be cumbersome. So of course we wanted to include experts by experience in our design. So we held 3 online focus groups with home care recipients and their caregivers, so a total of 17 participants in those. And then we followed up with online telephone interviews with home care providers themselves, so the actual clinicians, and we had 15 interviews. And we recorded those and analyzed them and had an iterative analysis of those transcripts to make decisions around sort of the face and content validity of this item pool matrix. So from a content validity perspective, does this measure have enough items to adequately cover the domains under investigation, or too many items? And from a face validity perspective, does it appear to be addressing the types of client experience areas that are relevant based on your own lived experience, either receiving or providing care? So in terms of our setting and participants, we were working in Ontario, Canada, as I mentioned, so we have quite a big population and have about 760,000 people receiving home care services. Our focus groups had 17 participants. We had clients and caregivers, predominantly female, and 29% were immigrants to Canada. In our interviews, we had nurses, personal support workers, speech-language pathologists, dietitians, and physiotherapists participating, similarly in terms of predominantly female, and some were immigrant to Canada. We had an older demographic and a more diverse population participating in our focus groups and in our interviews, which is interesting. So in terms of our results after the focus groups, participants felt like the item pool matrix had a really good face validity on its face. It appeared to be measuring what we intended to measure. However, they had a lot of recommendations about the content validity of our tool in terms of reducing the number of items that we had, combining some, and then renaming some that didn't really appear to be relevant from their perspective. So one that I've bolded here, and you can see is supported by the quote on the slide, is thinking about sort of the right amount of care and support instead of just the ability to self-manage. So it's more about having the right support than being able to self-manage from their perspective experientially. So after the focus groups, we ended up going from 3 domains, 14 categories, and 72 items to 3 domains, 14 categories, and 51 items. So some progress in reducing our number and sort of reorienting some of the language, but still more work to do. So then we took that revised item pool matrix to our interviews with clinicians and providers in home care. And similarly, they felt like it had good face validity from a content validity perspective, though similar idea around reducing some of the items or removing some. And here, they felt that we had too many questions related from an equity perspective related to the experiences of discrimination, and felt like those could be combined so that we didn't miss any subjective experiences of discrimination that people may have by trying to name them all individually. We also, a major change here was they felt that we should be separating out life care and the receipt of that life care from the delivery of that care through a relationship lens. And so that was a new domain that was added at this stage. And one thing they really focused in on was the delivery of care through a kindness perspective. So after the interviews, we went from 3 domains, 14 categories, and 51 items to 4 domains, 16 categories, and 37 item contexts, really thinking about that relational caring aspect. So from that sort of revised item pool matrix, we then went on to prototype our tool, including turning those item concepts into appropriate stems and then scaling our tool appropriately with the Likert type scale. And now we're moving into the next phase of our study. We've actually done most of phase 3, so testing the usability and clarity of the questions with cognitive interviewing, and there's actually a poster on that in the gallery if you're interested in looking at it. And we're moving into a more detailed psychometric testing phase of our tool, where we're piloting it with 300 home care recipients in Ontario. So a key learning for us is really that context and lived experience matter. I don't have to tell anyone in this room that, because it seems like we all are here for that particular reason. But in terms of survey design and meaningful survey design and the rigor in that process, it's really important to engage with experts by experience to make sure that the eventual tool that is used is really meaningful, not just to decision makers, but the people actually filling out the survey, because they're more likely to do it if it means something to them. So you can see the participant quote here, which really illustrates that. And this was one of our focus group recipients. So the more patients we get involved in more different areas, the more we can change the system, and you can really make a difference. And just being here today is going to make a difference. So thanks very much. I'll leave it at that.
Thank you so much, Justine. That was a fantastic presentation. I'm really excited about this new PREM. Do people in the audience have questions? I see one in the middle We have the microphone coming to you. Do we have it on? Oh, good. Great, thank you so much, Justine. So join me in thanking her for her presentation. And last but not least, our final speaker is joining us on Zoom, so fingers crossed for technology working in our favor. It's Jim Phillips talking about, is a unified model for patient empowerment possible or desirable? Take it away, Jim. Hopefully we can get you up on our screen.
Thank you. Can you hear me?
Yes, very clearly, thank you.
Good, excellent, thank you. Welcome. Firstly, apologies can't be there in person, but we had a family bereavement recently, which obviously made things a bit more difficult. I'm going to be covering this from a slightly wider angle in a way around just why patient citizen empowerment is so fundamental and inclusion is so fundamental in delivery of healthcare services. And I still find it odd sometimes that we're still having the conversation around why we should include people with lived experience. To me, it's absolutely fundamental. How can you develop a service, provide a service without them being involved right from the very start? Patient empowerment has a long history going back to the 1960s. And whilst there's been a huge range of terms around citizen engagement, patient participation, patient activation, health literacy, the fundamental underlying principle is still the shift from the patient citizen as a passive recipient of services to someone who's active and informed and a full partner in their care and in services as well. And a lot of these shifts have been reflected in policy and in the UK in particular around personalised care and integrated care as well. And they all put forward sort of models of working that are designed to enhance patient empowerment, a real shift from a biomedical model to a much more biopsychosocial model. However, despite many years of policy and inclusion, this agenda still, in our mind, remains very, very fragile. And I think the concept of empowerment needs to underpin what we're doing around interventions and the way we work and the way that we include people with lived experience as well. And the way we can do things can be about empowerment, or they can be about a real subtlety around actually increasing compliance and actually trying to fit people's lived experience with our more own sort of subtle biases and agendas. So if we look at interventions such as, say, self-management or self-care, for example, we could say that these can be a way to improve patient compliance with certain health behaviors. You know, we have sort of bad health behaviors, smoking, eating McDonald's, drinking too much alcohol as deemed as bad, and somehow we should be persuading people from not doing them. And of course, choices such as sort of running and meditation and yoga and eating healthy as seen as good. And the problem with this sort of dialogue is that it's very subtly shaming, particularly for people whose access to the opportunity to live a healthier life is significantly restricted. And I think that came out very well from our Australian colleagues' presentation earlier. They don't get asked in the same way. They don't have the financial resources. They don't have the capability. So there's a very we need to be very careful around how we frame this whole thing and how we frame our language about it. So for us in SENPAC, we see empowerment approaches are very much that they support and enable people to have the capability, the opportunity and confidence to make informed, and this is really important, conscious decisions about their health, and to ensure they have the opportunity to carry them out on a day-to-day basis based on what is important to them. So their values, what's important to them. And we know for many people, particularly around health inequalities, quite often issues such as housing, debt, employment, and so on are actually far more important than often managing their own health condition or supporting their children to manage their health condition can sometimes be more important. So in that, actually, unless we look at everything in the wider context of health inequalities as well, and really hear those voices of people with lived experience coming through very clearly, it's very hard for us to truly develop healthcare services which are empowering and actually are supportive of people's their values and what's important to them and what matters to them. So without involving those voices right from the very start, we will always get it wrong. We carried out some surveys back in 2021 to explore the current understanding of patient empowerment, and we included a survey of experts. And when we talk about experts, we mean experts, medical experts, service design experts, and experts in lived experience. And across a number of European countries, 14 countries, we got responses from. And we also followed up by an international roundtable event of people of lived experience, researchers, policymakers, to really explore this concept further. To put it simply, there's no overarching consensus on what a strategy for local implementation, or even how patient empowerment is defined for strategic purposes. And this, I think, is why we see so much variation in terms of policy and strategy, because there's so many sort of different positions around with this topic. And this has implications. The diverse definitions makes it harder to implement. There's no common understanding around the different concepts. And also that these findings confirm that these concepts, such as person-centered care, personalized care, and patient empowerment, have huge variations in how they're understood and therefore how they're implemented. So you've almost got to ask, is it meaningful to talk about patient empowerment as a definition, or is there a better term to use as an umbrella concept? And like I say, this has real implications for understanding the macro, meso, and micro levels because of the degree of fragmentation. And we see this a lot in the literature. We see it in literature reviews, where the diversity of concepts makes it harder quite often to build up the evidence base and have a more common approaches to make it easier to implement. What we found was a huge range of concepts and interventions: shared decision-making, self-management, self-care, health literacy, activation, behavioral sciences, health coaching, peer support, all being fed into this concept and feeding off each other. And what we noticed within those fields, quite a high degree of silos in terms of how things are being produced and put forward. And we see this quite a lot as well around in the development of PROMs and PREMs, patient-reported experience measures, patient-reported outcome measures as well, and a variation around them depending on how this concept is being approached and how then this thing is framed when talking and involving people with lived experience. We know all of this is really, really fundamentally important. This was, again picked up in the presentation on mental health earlier. We know that patients who have the confidence, capability, and motivation to manage their health have much better health outcomes. They have shorter stays in hospital, fewer GP appointments, fewer emergency admissions. We know that they're less likely to have comorbidities, they have lower mental health, better mental health, and their disease progression is much slower than those people who are at the other end of the scale. So working this way has a fundamental impact on people's healthcare outcomes. And we know that where clinicians are not sufficiently trained in involving people in decisions about their care costs money, it produces poor outcomes. So poor shared decision making, litigation, fail to warn, failure to do proper informed consent costs in the UK an average of £38 million per year. So we could save nearly £30 million just in people taking the NHS to court because they didn't feel properly informed and involved in their decision. Healthcare utilisation, we know poor shared decision making means that far more people go through to have operations that they did not want or have treatment regret afterwards. Yeah. And things like coronary heart disease and so forth. Huge number of medications are not taken as prescribed because people don't feel fully involved in their care. And the root cause of people not feeling fully involved in their care is around the training of clinical teams, ensuring that there's adequate support to give people the confidence, skills and opportunity to be involved, but also because we're just not designing the way we provide healthcare in a way which makes that possible. You know, linear pathways, for example, push people through particular processes. So that's a very sort of short overview, which sort of covers the survey we did and some of the thinking we've been developing over the last couple of years. And sort of key to this going forward is that people with lived experience have to be involved right from the very start, not brought in at a later point as an add-on or as a way of seeking endorsement for what we've already started to do. We need high quality training for clinicians to genuinely support literacy and empowerment and to generally understand why involving people with lived experience is absolutely fundamental in their service provision and the way they go about it. And we need far more resourcing to empower people to self-manage and to be in control of their health and well-being so they genuinely can be involved in their care and how their care has been provided. So I'm going to stop there. Thank you very much. So, good.
That brings us full circle to a very rich discussion. So we'll open it now to questions, first to Jim and then to all the speakers that you've heard today in this session, not today. So any questions for Jim? Okay, we have one. So Jim, bear with us as we're bringing the microphone.
Thank you, Dirk Brooks. I'm a pharmacist here in Antwerp. You opened the discussion on the fact that there is no clear consensus or definition of what patient empowerment really is. But what's the definition for you then?
Very much. Empowerment is, where someone is able to make informed and conscious choices around how they want to manage their health and well-being. So I think that's key, informed and conscious choices. A lot of the choices we make are often reactive, might be based on beliefs we have around the causes of our ill health and what's caused it. So for us, that's very much where we're coming from, this idea of informed and conscious choice, the ability to make those choices, which might not always be in line with what is the clinician might think is the correct choice. So in shared decision making, the choice of doing nothing is as an important and equal choice as that of active care. And this might be particularly so in, say, cancer or end of life.
Good. Thank you, Jim. Any other questions? Yes. I see two raised hands. First the gentleman and then another lady in the back.
Thank you. I have one question for Russell Roberts, but if I could just make a really fast comment. I really enjoyed that presentation from Southeast Health. We had a very similar one at UHN and they had an hour to fully explain a lot of the amazing work they've done. So Unfortunately, you only get 10 minutes. I wish we had an hour because I would have really liked to hear that. Back to Russell Roberts. Quick question for you. I agree, what you were saying, that poor physical health leads to depression and suicide and so on. So what I'm wondering is, do you have any suggestions regarding early indicators in terms of physical health? What can we look for in a person that can possibly predict a greater incidence of eventually suicide or depression?
I think that's a great question, and I think the answer is what we look for in everybody else. So it's good preventive screening. There's also, of course, the social determinants, and for us, the rate of premature death skyrockets, goes to 6 or 8 times for lack of community participation. So being involved in the workforce, etc. So in one respect, it's social exclusion, which is one of the biggest predictors of poor physical and poor mental health. But I think that also goes with a lack of access to, health promotion messages and also health prevention screening messages, which, so many of us have. But people with mental illness will go without this for 30 years, having had contact with that. So I don't think I've fully answered your question, but that's my sense of it. Thank you.
Thank you, Russell. And Greg, the last table over there.
Thank you. Russell, I wonder if I could ask you, you just kind of made me want to ask you a second question now, so just hopefully they'll be quick and I can all chat to you later. But I'm interested in evaluating holistic care processes as part of experiences of person-centred integrated care. So when you talk about, we trained them in holistic care, I'm just interested in how that looked, or what that training constituted of. And then secondly, and maybe this is for later, but just that the social component of integrated care, and I'm wondering, when you're talking about identifying social exclusion, do you see integrated care providers having a role in providing that social care, or is it more a case of the integrated care team signposts outside for that social component to be met, for people to be included in society?
Wow, great questions. I was talking before about you can chew gum and walk at the same time. I think you can be a clinician and a social advocate at the same time, because the challenge as a clinician is you need to address personal pain and however it presents. But often that personal pain is due to major social factors like discrimination, stigma, exclusion, etc. Well, we don't control that. That's a social politics thing. But we can still advocate for that at the same time. In relation, and Jackson talks about this in a community development continuum, where you address a social pain, and we can think about that in domestic violence or body image as well. You don't discount the person's experience, why they present. But you still do need to understand the causes of that, which is a thin body ideal or the masculine, self-entitlement, etc., which is underlying, so many of the ills of our community. In the question of holistic care, our view is that and we talk to psychologists, etc., you don't have to be an expert in everything, but you can be an advocate. So we say, ask, assist, advise, and advocate. So once again, this is the freedom, like us. Would you like to quit smoking? With Jim was talking about, well, no, I don't. I've got so many other things I'm trying to cope with in my life. That's fine. Would you like to have a vaccination? No, I don't. That's fine. That personal agency and autonomy is central to health, in my view, to make the choice. You make your own choices for your own health. So you can ask, and then if they say yes, you can assist and advise, and if necessary, sometimes if necessary, you can advocate. You don't have to be a specialist we were talking about diabetes before, in ophthalmology or podiatry in order to advocate that someone with diabetes gets good, eye care or foot care that they need. Because you're a professional, you've got some power. We talk about empowerment. I think structurally, people with illnesses are disempowered. People from marginalised communities are disempowered. We have decades of the medical specialist being the powerful person, and then the allied health being the next powerful, and the poor old patient being, and I use the term advisedly, the patient, that's a hierarchical relationship, being the disempowered. And I don't like the word empowerment either. I like to think we equip people to get equitable access to care. So our view is every clinician doesn't have to be an expert in everything, but you do have some power in a health system, and you can ask, assist, advise, and if necessary, advocate. And I think it's our job to ask about holistic care, even if you're a if you're a podiatrist and an ophthalmologist, a GP, psychologist, social worker, we're talking about a whole person, and that person has trust in us when they contact us. We shouldn't betray that trust and just focus on that one little bit, when in fact we've got an entire life, a life full of social networks and goals and aspirations that we need to be sensitive of, and that's the context in which we work and we should respect.
Excellent, thank you, Russell. Any other questions, comments, reflections? I don't see any. So with that, I think it's been a really enriching session. We sort of did a tour around the world from Norway to Australia and Canada and the UK. So I hope it was interesting and useful for all of you. Thank you so much to our speakers and to my co-chair, Carrie, and enjoy the evening reception in the beautiful zoo. Thank you.